So there are three main markers that are really promising for selecting patients for neoadjuvant chemo. They're all still under development and need to be validated, but they really look pretty good. So the first one I'd highlight are molecular subtypes of bladder cancer. So we can classify bladder cancer based on RNA expression. And the general gist is that it can be classified into basal and luminal tumors. And there's some retrospective data that shows that the basal tumors do particularly well with chemo, whereas they have a poor prognosis without chemo. So they seem to have, it looks like a predictive marker, and we could think of prioritizing those patients for chemo if we can validate that marker. A second marker is called the Coxon model, which is a complicated algorithm based also on RNA expression that compares a patient's tumor to sort of a database of gene expression with known response to chemo. And so whatever chemo agent you want to give, you can look in the individual patient and see how likely they are to respond. And again, you can decide to treat a patient maybe with something else or not at all and move on to surgery. And the third group of markers which look very promising are mutations in DNA repair genes. So genes like ERCC2, ATM. And there are a couple of groups in the US that have looked at this, again in retrospective series or post hoc and prospective trials, and see that they really predict response and survival after neoadjuvant chemo with really a marked separation between responders and not, or between mutated and not mutated. And again, those are in clinical trials, and hopefully we'll get validation, and then this will actually change practice in the not too distant future.